Hi, everyone. My name is Trisha Agarwal. I am a recent graduate from UCLA, and today I'm going to be presenting our project from the UCLA Department of Emergency Medicine, which is titled Emergency Department Bounce Back Rates for Pediatric Patients with Respiratory Illness. Before we dive in, I just want to give a huge thanks to Dr. Lee, Ruth McConnell, Dr. William Mower, and Dr. Malkeet Gupta for all their work and support on this project. So to get into the background of this project, about 30 million pediatric patients present to the ED every year, which leads to about 1 million bounce back visits in that same time period. And studies mostly agree that the majority of bounce back visits are usually related to the initial visit. Now, 1/3 of these pediatric emergency department visits, though, are related to respiratory illness, which represents a large portion of bounce back visits. An analysis of this large subgroup of patients is actually pretty limited, and any related studies have mostly been retrospective. So our study is trying to look at this prospectively. So our aims for this study, though, were the following. Is there a significant difference in return visit rates between pediatric patients who present with varying respiratory illnesses and those who present without respiratory illness? And if so, we wanted to determine if there are certain factors that significantly increase rate of return by comparing demographic information amongst the two groups. So the way that we went about this is by doing a prospective cohort survey. We did this at one academic teaching hospital, which was UCLA Ronald Reagan Hospital, and then we did it at a community hospital in Antelope Valley. And both of those are located in LA County, and combined they see about 170,000 emergency department visits. And we collected data from February 2019 to February 2020. So the data that we collected was surveys from the treating providers. So we asked things like, what's the patient's diagnosis? What are the treatments they're getting? What's their disposition? And then we also did structured chart review where we were able to get demographic information as well as vital signs. So when it came to enrolling patients, we enrolled any patient that was under 11 years old that presented to the ED from 8 a.m. to 12 a.m. And then we excluded anybody that was admitted, that eloped, that left against medical advice, or if there was a diagnosis that wasn't provided. So this gave us a sample size of about 3,000. So this is kind of an overall breakdown of the diagnosis determined at the initial visit by emergency medicine providers. So the return rates and relative risks are provided here for patients with both with and without a respiratory illness. Now, our results demonstrate that there is a significant increase in return visits for those children who present with respiratory illness when compared to patients who present for other pathology. And then given that nearly 1/3 of pediatric emergency department visits are related to respiratory illness, it was really important for us to assess if all types of respiratory illness actually contribute to the increased risk of a return, or if it was one or more specific respiratory illnesses that cause the increased rate. So we grouped patients with severe respiratory illness like asthma, reactive airway disease, pneumonia, and bronchiolitis. And as expected, we found that these patients had a significantly higher return visit rate and significantly higher relative risk. However, when we compared this group to patients with less severe respiratory illness or viral upper respiratory illness, we found that they also had a significantly higher return visit rate and significantly higher relative risk. In addition to this, we looked at demographic information, sex, race, time of day, and day of week, but we noticed that those did not significantly impact return visit rates. However, we did notice that younger children were significantly more likely to return to the emergency department. Specifically, patients under the age of 1 year old were at greater risk to suffer a return visit. And children under 1 year old with respiratory illness also have an increased risk of return visit. But interestingly enough, age was not a significant factor for children who presented for non-respiratory pathology. Now, there are some limitations, though, to this study. One limitation was the skill level of the provider determining the diagnosis of the patients who presented. Both hospitals are academic teaching hospitals with varying resident involvement. So residents ranging from their first year to their fourth year and mostly specializing in emergency medicine were the primary treating physician for the majority of the patients. And this data also only represents only 2 hospitals, and the results may not be consistent with other practice settings. However, in order to perform a prospective cohort study and accurately capture the diagnosis of the patients involved, performing a national study would definitely be difficult. Another limitation is the distribution of race and ethnicity. A large proportion of the sample size was Hispanic, which is greater than average for the United States. And research has suggested that patients whose primary language is other than English are more likely to return to the emergency room. And this factor could contribute to the higher return rates experienced in this study compared to others. In addition, on occasion, the determination of a patient's diagnosis was not known at disposition. And in those situations, the treating provider would make a diagnostic determination before having all the relevant information. For example, there could be a situation where a stable patient was discharged before all lab results had resulted. And in those situations, the provider might have chosen either viral illness or bronchiolitis prior to knowing the definitive results. But despite these limitations, overall, children younger than 11 who present with respiratory illness are more likely to return to the emergency department for another evaluation within 7 days. And even children with less severe respiratory illnesses like viral upper respiratory illness are more likely to suffer a return visit. And those children under 1 year of age and suffering from respiratory illness are especially high risk for a return visit. But those who are not suffering from respiratory illness are at no greater risk of returning. But since respiratory illness is a common complaint amongst pediatric emergency department visits, quality measures should target this more at-risk group. While return visits might not lead to worse outcomes or higher costs, these return visits could be preventable and lead to help with emergency department overcrowding in the future. So that's the takeaway from this presentation, but I just wanted to acknowledge all of the individuals on this list who helped contribute to this project. And if you have any questions, feel free to reach out to me or Dr. Lee via email. And with that, thank you so much for listening.